Welcome to the Recess Room Podcast.
5, 4, 3, 2, 1, fire!
So hi, and welcome back to the Recess Room Podcast. I'm Simon Lang.
And I'm Rob Fenwick.
And Happy New Year. Happy 2020.
Oh, yes. Hopefully you'll be listening to this at 1 a.m. just as it's released. But yes, Happy New Year indeed.
Some people might actually be working, Rob.
Oh, really? Well, it isn't me. Well, I hope it isn't me.
Anyway, hope you've all had a fantastic Christmas. You've enjoyed some appropriate New Year's Eve celebrations. And we're looking forward to bringing you some fantastic new evidence-based medicine for 2020.
We are indeed. So we've got our usual absolute awesomeness in the form of Roadside to Recess. We will have our regular updates in forms of papers of the month. We'll have a little bit of conferencing coming up and some other exciting projects. So thanks for listening again and stick with us. We've got some exciting stuff coming.
We have indeed. And before we crack into the podcast, a big thanks to the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine, who are the collaborators with us in this podcast. Every month we'll be bringing you one of their papers, and all of their articles are free and open access, so go and check them out on their website, which we've got a hyperlink to on our website. So without further ado, let's crack on with the papers. So, we're obviously biased, but we have got 3 really interesting papers, actually, which will make you think about the way that you practice. So we're going to be having a think about the diagnosis of pulmonary embolism and whether or not we're over-investigating a bit. We're going to have a look at a paper that looks at rewarming rates in hypothermia, which is pretty relevant to this time of the year. And finally, we'll be having a think about whether or not we should be performing whole-body CTs for patients who've got a return of spontaneous circulation after cardiac arrest. So paper number 1, as we've alluded to, is on pulmonary embolism. The title of the paper is Diagnosis of Pulmonary Embolism with D-dimer Adjustment to Clinical Probability, the PEGED trial. It's published recently in the New England Journal of Medicine, and the lead author is Clive Kieran. Now, to give a bit of context to this, I think it's fair to say that we've all got pulmonary embolism in our minds when we see somebody that presents with chest pain. And when it becomes pleuritic, when there are some risk factors for PE, the index of suspicion appropriately goes up. But there's also concern that we're over-testing. And actually, whether or not these pulmonary embolisms are actually physiologically normal entities, and whether committing people to a period of anticoagulation is actually in the best interest of our patients, if we're going to go down that diagnostic route and accept that the way we test isn't necessarily perfect. So there have been a number of things that we've looked at. We've looked at age-adjusted D-dimers, in which we accept the fact that as patients get a bit older, their normal D-dimer level is going to be greater. We've had a look at the PERC score, and of course, there's that good old trusted WELL score that we can use to risk stratify patients. So in this study, they looked at adult patients with symptoms or signs of pulmonary embolism presenting to EDs and outpatient departments in Canada. Now, importantly, they excluded patients who were already on full-dose anticoagulation therapy, had undergone major surgery in the last 3 weeks, had got a known D-dimer level prior to the clinician working out what the likelihood was of them having a PE, and those that were pregnant, including some others. So it was a multi-centre prospective enrolment. And pretty similar to practice that we'd see over here, patients had a WELL score calculated when they came in with a scale of 0 to 12.5, like the one that you find on MD Calc. They then categorised these not into just low and high risk, but into low, moderate and high, as you can do with the WELL score. So a low clinical pretest probability was a WELL score of 0 to 4, moderate was 4.5 to 6, and high was 6.5 or greater. Those with a low to moderate clinical pretest probability had a D-dimer sent. Those that had a high clinical pretest probability went on to radiological investigations straight away.
So just in terms of what that would mean to my practice working in my centre, we typically have a system whereby if the patient has a low WELL score, we will then send a D-dimer, and if that is negative, we'll rule it out. But in this case, what they've done is they've included the moderate category as well. So it's not just low and then D-dimer, it's low or moderate and D-dimer that's then sent.
Yeah, and it's a little bit more intricate, the way that they're working these patients up. So going and having a look at the paper and getting your head around it is a wise thing to do. But what they then do is they use this pretest probability and then adjust the level at which the D-dimer will be deemed to be positive. So if you've got a low clinical pretest probability, then you use 1,000 nanograms per milliliter as the level of a positive D-dimer. And if it's moderate, then that drops down to 500, which is probably where people are more used to calling a positive D-dimer level. So if you're low and it's less than 1,000, there was no more investigation for a pulmonary embolism, you didn't get any anticoagulant therapy, and if the clinical pretest probability was moderate, then you went for 500, and if it was less for that, again, no further investigation and no anticoagulation therapy. All of the other patients, if they couldn't rule out the fact that they've got a pulmonary embolism, went on to have imaging such as a CT pulmonary angiogram to look for the presence of a PE. So at this point, following serum testing and following their pathway of radiological investigations, they determined whether or not the patients had got the PE. The comparison they're making is follow-up at 90 days, and this is made over the phone or in clinic. And the primary outcome was if at 90 days they were symptomatic or objectively had a verified venous thromboembolism, which included PE or DVT. So essentially, if you were part of the negative workup, so you've got a low clinical pretest probability, a D-dimer of less than 1,000, you went home, they want to then check at 90 days that you haven't got a PE or a DVT. When those patients were sent home from their initial testing, they were told to return to the emergency department if their initial symptoms didn't improve, or, as you would do, if new symptoms developed which were compatible with DVT or PE. And the study was powered to rule out a percentage with venous thromboembolism of 2%. So Rob, there's quite a lot of methodology there, but essentially we're looking at this new strategy and whether or not using low, moderate and high clinical pretest probability with Wells is going to be a way that we can safely reduce the amount of imaging we're doing to find PEs on patients.
So essentially what we're looking at is to decrease testing further, so to decrease those unnecessary tests. There's two potential approaches then, I guess. So there's the increasing of the acceptable D-dimer rule-out range or increasing the pretest probability to include moderate risk. Is that a fair summary then?
Yeah, I think that's much more succinct than the way that I've just put it.
well, any chance of any results anytime soon?
Go on then. So there were just over 3,000 patients that they assessed. And of these, about 2/3 met the inclusion criteria. The prevalence of PE in this group, which I think is really important to think about, is around 7%. And I think that's about the prevalence that I've been aware of in EDs that I've worked in at the UK.
Yeah.
Average age of the patient was about 52. 2/3 of them were female, and follow-up was achieved in 98% of the study population. So on to the results, and I hope you're concentrating. So of these nearly 2,000 patients who had a low or moderate clinical pretest probability with a Wells score and had a negative D-dimer, so essentially were ruled out as having a pulmonary embolism by this new low and moderate cut-offs for D-dimer, none of them went on to have a venous thromboembolism during follow-up.
Oh, looking promising so far then.
Now, of the 40 patients who had a moderate clinical pretest probability, so that Wells score of 4.5 to 6, and a negative D-dimer result, so the sorts of patients that you might consider doing imaging of their chest already, but they didn't in this study, none of those went on to have venous thromboembolism during follow-up. And the conclusion from the paper was that with this diagnostic strategy, it resulted in the use of chest imaging in this cohort of patients with a possible PE of 34%. Whereas a standard strategy, as defined by this cutoff of 500 nanograms per milliliter, would have resulted in 52% of patients getting scanned. So a difference of around 18% of patients who didn't have to have radiological investigation of their chest for PE. So quite a difference.
Oh, that is quite the result, isn't it? That is awesome.
Yeah, it does sound like a really interesting strategy. So we were lucky enough to get the thoughts of the lead author, Dr. Clive Kieran, who's a professor of medicine at McMaster University and a member of the Clinical Thrombosis Service at Hamilton, Ontario. And here's what he had to say about the study.
This study evaluated a new way to use D-dimer testing to help rule out pulmonary embolism in the emergency department. Instead of using a single D-dimer value of 500 to define a negative D-dimer result, we used two values, a value of 500 units for patients who were judged to have a moderate probability of having pulmonary embolism, and a value of 1,000 for patients who were judged to have a low or an unlikely probability of having pulmonary embolism. This new approach to D-dimer interpretation enabled us to reduce the number of CT pulmonary angiograms that were required by 1/3 without compromising diagnostic safety. This was a prospective cohort study, and a challenge of prospective cohort studies is having physicians enroll patients in a non-selective manner. We want to avoid just enrolling low-risk patients. We monitored this possibility with study screening logs, and they suggest that selective enrollment was not prominent and was unlikely to have undermined the study's findings. What does this mean for practice? Provided patients are first assessed as having a low clinical probability of having pulmonary embolism, this diagnosis can be considered excluded without the need for CT imaging or the need for anticoagulation, provided this approach is used, and it will reduce the use of CT scanning in these patients by 1/3. I consider that the next step is to get this message out so that we can use this new knowledge to improve the care of individual patients and the efficiency of healthcare delivery in general.
Well, that's brilliant. And thank you so much to the lead author for taking the time to come on the podcast and talk about this great piece of work. So, Simon, what are your thoughts on this study?
Well, I think the sorts of studies that catch our eye are the ones that we really feel can make a difference to the frustrations that we find in practice. And I think the times at which this really feels like it could be useful are those patients that you really don't think they've got a PE. And what's interesting is in this study, they didn't use the age-adjusted D-dimer, where over the age of 50, we multiply their age by 10 and we use that as a cutoff. So I don't think we just use, certainly in my practice, 500 as the D-dimer cutoff as negative. I think sometimes we go a little bit higher. So it potentially doesn't rule out quite that many scans. But you can certainly imagine that 40-year-old patient, can't you, that's got a D-dimer that comes back about 560. Perhaps if you're reviewing the patient for another clinician, you wouldn't necessarily have ordered the D-dimer. And you can see how this sort of paper could really support the idea of not going on to do any further testing if their Wells score was low.
Yeah, absolutely. And I completely agree. And I think this is a really great piece of work, and it's really potentially game changing in a strategy where we can try and reduce over imaging of patients. I think from a critical appraisal perspective, I think it would have been nice from a gold standard perspective to have definitive evidence of whether that person had a PE, but it's completely, this is a pragmatic trial, I think, from that respect. And actually, you know, we're not going to image every single person who comes through the door, and it's not ethical to from that perspective either.
And I guess we also don't truly believe that a CTPA is actually a gold standard test, do we?
No, you're absolutely right, because, you know, there will be false positives included within there, won't there? And I think that, you know, as the authors state within their discussion, it does need validation in the UK and Europe. So that is something that you'll need to just keep your eye on. But this is a phenomenally important area, and this is a great first step, and it's a really important thing to go and have a read about. It's great.
Yeah, I don't think it's something that quite at the moment, with the way that UK guidelines are framed, that I'll be using as a blanket approach. But I think it's one of those pieces of evidence, as we suggested, that we'll use to support those patients that really do not seem to have a PE. And when in a bit of a joint decision-making process with patients, then it might be a way of saying, we think we've got enough evidence to say that you really are unlikely to have a PE, and we think it's best to stop investigating you at this point.
Also, just to point people in the direction of some really good blogs by Rebel EM and St Emlyn's with regard to this paper. So if you want a bit more depth around it, go and read the main paper and then have a look at those blogs on top of obviously listening to our work as well.
Excellent. Well, on to paper number 2 then.
Okay, so paper 2 this month is titled The Impact of Rewarming Rate on the Mortality of Patients with Accidental Hypothermia, an analysis of the data from the J-Point registry. Ooh, J-Point topical, Simon?
Is it?
J-Point on ECGs. Yes, it is. Anyway, yeah, if you want to know about ECGs and hypothermia, don't ask Simon Lang, apparently. So, okay, bit of background to this. So, accidental hypothermia is defined as an involuntary decrease in core temperature to less than 35 degrees Celsius. And we see this pretty frequently in the ED, even in the United Kingdom, which relatively isn't that cold, I guess, although it's pretty cold at the moment when we're recording. Now, a previous study has stated that the mortality rate of patients with accidental hypothermia is as high as 30%. So this is important. Now, particularly though, with regard to those numbers, around 28 degrees Celsius is when things get really tasty and there is a high risk of cardiac arrest. So we've previously done an episode on hypothermia, so go and have a little listen to that.
What a plug.
What a plug, I know. Scandalous. We'll just plug the back catalogue. And this covers the main methods of rewarming. But, and as we said at the time, there isn't a huge amount known about the optimal rewarming rate. So why might this be a problem? Well, on one hand, you really want to rewarm your patients quickly to avoid the potentially fatal complications such as cardiac instability, and we've already talked about that. But rewarming also has problems, so it's associated with a number of issues such as hypotension, so the after drop that we typically call it, also things like neutropenia, electrolyte imbalance and GI bleeding. So there is a bit of equipoise about what is the right rate to rewarm these patients. So this study has a look at that. So this was published in the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine, and the lead author was Watanabe. So what did they actually do then? So this was a retrospective study of patients admitted to one of 12 hospitals in Japan from 2011 to 2016. And they had a registry, so it was called the Japanese Accidental Hypothermia Network Registry, or in this case, the J-Point. So there were 572 adult patients in this registry, of which 481 were actually included in the analysis. So this paper looks at 481 patients in that 5-year period. Now, they were all included if they were coded as having hypothermia, so you had to be coded as that, and that was defined as a temperature of less than 35 degrees. They also excluded patients that didn't have either a temperature or their rewarming rates documented in their notes. So they collected data on numerous different baseline characteristics, on biochemistry, on the SOFA score from an ITU perspective, and also the treatment processes. Now, the key bit that they looked at was they calculated the rewarming rate based on the body temperature on arrival and the temperatures during rewarming and the overall time spent rewarming that patient up. And they evaluated the association between rewarming rate and the outcome. So they split it into 5 categories nominally. So in terms of how quickly these patients were being rewarmed, it was split into 0.5 degree Celsius differences. So the highest category was more than 2 degrees Celsius per hour. Then there was 1.5 to 2 degrees per hour, 1 to 1.5, etc., until the lowest was 0.5 degrees per hour. You with me so far?
I certainly am.
Oh, that's a relief, because if you're with me, I know everyone else will be. You are the lowest common denominator here.
Why, thank you. Oh, that's not a compliment.
No. So the primary outcome that they were looking at was in-hospital mortality. Now, Simon, I'm going to have to tell you that the overall mortality was a pretty painful 21%. So these are a sick group of patients, and that fits with the literature we've looked at. But remember that we're looking at rewarming rates. So do you think that mortality rate was highest in the slow rewarming group or the fast rewarming group?
So I think there are going to be some patients that are so sick that they're really difficult to rewarm because essentially they're dying from either hypothermia or from the other disease processes that they've got going on. And with concerns that exist about warming people up too much, then I guess the mortality rate is going to be highest in that group. So I would expect that there's going to be a sweet spot right in the middle, which is going to be the bit that we're going to aim for.
So you're sitting on the fence then, yeah? Nice. Okay.
Well, I'm not going to be too wrong in either direction, am I?
No, fair enough. So in terms of the mortality rate, so the mortality rate was highest in the slow rewarming group. So if you were only able to rewarm your patient by 0.5 degrees per hour, the mortality rate was 35%. Now, if you look at the fastest rewarming group, so the 2 degrees per hour plus, then the mortality rate was 19.3% in that group. So actually there was a 15% mortality rate difference. Now that gave an odds ratio of 4.09 with confidence intervals that were wide but did not cross 1. So they did some multivariate regression that also showed that mortality increased with every 0.5 degree reduction in rewarming rate. Okay, so what this effectively points towards is that your patient is better off, or the mortality rate is lower if you're able to rewarm them quickly.
Also known as my prediction was wrong.
I mean, you can describe it in many different ways, but yes, that is correct.
Simplistically, it's a good blanket approach, I find, for most things that I say.
They did have a look at some secondary outcomes, so that was things like the incidence of VF and VT, so obviously them horrendous arrhythmias, and again the incidence of VF and VT decreased with faster rewarming, with again significant confidence intervals and an odds ratio of 0.55, but again not particularly precise, but a signal towards rewarming fast being a good thing in terms of mortality and secondary outcomes. So Simon, give me some thoughts.
So I think this is really interesting, isn't it? Because it's quite an evidence-light area, so it does give us a bit more fuel to the fire. Not that we should be using that as a rewarming strategy, but I think it is really interesting. However, I'm just going to take issue with one of the things that you said. So you talked about this as if they rewarmed a patient at a certain number of degrees per hour, but actually it doesn't really tell you about the strategy of which they're trying to rewarm these patients.
Yeah.
So it doesn't tell you with these that are rewarming more slowly that actually that's what was intended, or in the ones that you're rewarming quicker that was the intention either. It just shows you that when you apply a rewarming strategy, and that was a number of different strategies I think that they were using here, is that right?
Yeah, so I mean, there was invasive, so there was about 20 cases of ECMO, there was bypass, there were filtration techniques in terms of the invasive stuff and lavage, and then there was your sort of standard stuff, so your blanket rewarming, your warmed IV fluids, your heat packs. So yeah, there was a wide spread of things basically.
And the non-invasive ones were the type that were used much more frequently, weren't they?
Yeah, absolutely. I mean, the invasive, as you'd expect, the invasive rewarming techniques were used, comparatively infrequently.
I think what this would say to me is we carry on doing what we're doing already, careful handling with those with hypothermia, being aware of arrhythmias, and then actually being proactive and trying to rewarm people is really important to do. And when we see patients that we are proactively rewarming and we're not terrified at the rate at which we are rewarming them, if they're not warming up quite quickly, we need to rethink our strategy and see if there's anything else that we should be doing. And we also need to bear in mind the fact that that's a subtly poor prognostic sign for our patients.
Yeah, I think, all completely valid points. And I think this is, I think there are some issues with this study. I mean, it's retrospective. It's a Japanese study rather than a UK study. The rewarming methods were different. And, if you look into the actual patients that they had, a lot of these patients, they were cold and indoor. So this doesn't necessarily apply directly to those with pure environmental hypothermia or those exposure cases that we see relatively infrequently, I guess. But it doesn't necessarily apply to them. So you do need to take it with a pinch of salt. But I think you're quite right. I think as a start-off strategy, aim to rewarm your patients quickly, and then you need to adjust if you are not meeting those requirements would be a fair approach based, as I say, on this study and an otherwise pretty evidence-light area.
Right, well, on to paper number 3 then. So yes, paper number 3. So this looks at investigations following patients who've sustained a cardiac arrest and then have got a return of spontaneous circulation. So published in the American Society of Emergency Radiology, the lead author was Vinyl, and the title of the paper is Early Whole Body CT for Treatment Guidance in Patients with Return of Spontaneous Circulation After Cardiac Arrest. So before we go into it, Rob, if you've got a patient who's got a ROSC and you don't think that they're definitely a cardiac event, you haven't got an obvious answer as to what's going on, how many investigations and what sort of radiological strategy would you be using to investigate that patient in front of you?
How many investigations? I have to put a number on it. Am I 6? No, I don't know. So, I mean, from that patient you just presented me with, so I don't think it's a cardiac event. I think that my strategy currently is, you do bedside testing, so you'll do an ECG, you'll do a chest X-ray, you will probably proceed to doing a CT head, and you will get some biochemical markers sorted. You may or may not decide to image them further, either bedside ultrasound or using a focused CT approach based on what their clinical history was and their comorbidities. But essentially, that's pretty much my strategy.
Yeah, I think mine's pretty similar, and that it might include, if there's any signs of head trauma, that they get a CT scan of their neck. And PE tends to be pretty high up, I think, on people's differentials for these sudden cardiac arrests without a clear answer of what's going on. So I think a CTPA is something that we might be performing. But this study is looking at a really different strategy, so let's have a little think about it. So it was a single-centre retrospective study of consecutive patients with non-traumatic cardiac arrest. And it included patients both in and out of hospital with their ROSCs following CPR, and this is in a centre in Germany. So the intervention they did is they put these patients through a whole-body contrasted CT scan within 6 hours over a 12-month period. Over this period, there are 100 patients that met the criteria and were scanned in time so that we could evaluate them as part of this paper. So the paper really nicely describes the sorts of things that were picked up. So, for example, in the lungs, they found opacifications in 70% of patients, with pneumothoraces in just over a quarter of patients. They found rib fractures, as you probably might expect, in nearly 90% of patients. With regards to the head, they found in 12% of patients that there was global brain edema. They found pulmonary edema in 81% of patients, pulmonary embolism in 14% of patients, and then when it comes to the abdomen, they found things like splenic hematoma in 2% of patients, bowel rupture in 1%, and pyelonephritis in 1%. And there are a multitude of other things that they found as well throughout these scans, so make sure you have a look at the paper for the entire list of findings. But Rob, what do you reckon, considering the fact that we're not performing whole body CT scans on our patients who are undifferentiated following ROSC, what do you think about the idea of applying this sort of technique to our patients?
Well, I mean, this is a difficult area, isn't it? And so I read this paper on a train.
Well done.
And when I was reading this, I honestly, I don't know what people thought, but like my eyes were like, my brow was furrowed. I was like slightly clammy. I was like, oh my God. I mean, they found an absolutely staggering array of pathology on these scans, both, injuries and illnesses. I mean, in all respects, some could be incidental, but essentially some could be causative and some directly related to the CPR. And this was absolutely staggering to read, just the list of things that they found. Now, I mean, they recommend, of course, that you should be doing whole body CTs in all patients following ROSC, which, I mean, based on their study in their single centre, I mean, looking at that, you find it difficult to argue against it. I mean, I don't think I'm 100% convinced that we should be doing this in everyone, because I think there's different things you need to know, and it's in your system. What does this do to your patient in the long run? I mean, does it affect their actual fundamental outcome? Are the findings that we have acted upon? I mean, do they make a difference? I mean, in this paper, they don't report, as far as I'm aware, the interventions that the clinicians made after identifying all these additional things. So, I mean, what did the clinicians think when they actually found it? I mean, I guess the other thing is as well, could your service actually provide this imaging for every patient who comes in following ROSC without having a serious impact on all those patients that, do need it to focus their investigations and management? You can't argue the fact that clearly there's a lot of pathologies picked up on whole body CTs after ROSC.
Yeah, I think this is really, really interesting from a hypothesis generating perspective. And the number of patients that we scan with a whole body CT following trauma is actually phenomenally larger than the number of patients that are going to need a scan following ROSC. But this is a single centre study. It doesn't tell you anything about how that would affect outcomes. But there are certain things in here that you really do think might benefit patient outcomes by seeing them. And I don't know why, but there does feel like there's a bit of an inherent reluctance to do a whole body CT on this cohort of patients. And I think, to me, it just highlights the fact that when we've got a patient that's got some positive prognostic signs and we're a bit lost at the point of what could have been causing their cardiac arrest, it will make me think a little bit more about whether or not there would be a benefit to a more liberal scanning approach. Certainly not going to say, off what I'm sure the authors would be happy for us to say is a relatively low level of evidence, and as we said, hypothesis generating study, that we're definitely going to go on and perform whole body CTs on all of our patients. But I do think it's interesting because there are some things that are picked up here that you can't help but think would make a difference to the outcomes of the patients that they've got in this study.
Yeah, I'm with you. I think, it's certainly, having read this, it has lowered my threshold to request one, if that makes sense. It's lowered it. It's not put it like on the need to do list, but I think it's going to make for some very awkward conversations with radiology about, can I get a whole body CT on this patient? I just don't think it's accepted practice in the UK, or certainly not widespread in my centre anyway. So
no, and nor should it be, I don't think.
No, I think you're right, and but I do, like you, I think that it's, if you're lost and you don't have a cause for that patient's cardiac arrest, I think that this goes some way to show that you will pick up on things that you weren't necessarily suspecting. But yeah, a bigger study, a prospective study, looking at actual patient-centred outcomes would be great. But yeah, watch this space. Very, very interesting.
Excellent. Well, that is it for our New Year's Papers of the Month episode. So to summarise, we've had a look at the PEG-ED study, which looks at different D-dimer thresholds regarding your clinical pretest probability using a Wells score for patients with PE. And in that study, seen that in a very low-risk cohort, that maybe using a D-dimer cutoff of 1,000 might be a safe strategy to use. But we haven't seen that employed yet in the UK population. Had a look at a paper which has shown an association in hypothermic patients that actually quicker rewarming rates are associated with better outcomes. And finally, we've had a look at this single centre study which looks at the fact that whole body CTs on patients in this cohort with a ROSC yielded a phenomenal amount of information and may or may not enable us to deliver better outcomes for our patients. And I really hope we're going to see some more evidence on that area soon. So a big thanks to SJ Trem, the partners of the podcast. Go over and have a look at their website and all of their articles, which are open access and relevant to the sort of topics that we cover here on the podcast. If you're interested in critical appraisal, go over and take a look at our critical appraisal podcast course at criticalapraisallowdown.co.uk. We'll be back with you really shortly on a roadside to recess on seizures. So until then, take care of yourselves and we'll speak to you soon.
Speak to you soon.